This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
My talk, however, is on governance of rapid response systems in the private hospital. Now, I'm from the Epworth Hospital in Melbourne. You can see the Epworth there, the Richmond campus. It's beautifully located, very close to the city, nice sort of boutique shops and cafes along there. Really a very pleasant place to work. So the Epworth Healthcare is the largest not-for-profit healthcare group in Victoria, and Epworth Richmond is actually a tertiary facility, very much like a public hospital, I guess. It's got a 15-bed ICU, a 24-hour emergency department, which cases to really all major types of surgical and medical subspecialties. I'm one of the senior intensivists there, and I guess my experience for this talk comes from the fact that I was the previous chair of the hospital's Rapid Response Committee and helped set up a rapid response system at that hospital. So we had a track and trigger rapid response system proposed in 2007, and I put that black and white picture up there for a reason. I felt that a lot of the people are trying to convince were certainly stuck in the 1930s, where that picture is from of the Epworth Hospital. It was very much like trying to put a square peg in a round hole. Now, the challenges weren't just specialist buy-in that we had, but to be fair, it was only a small proportion of specialists. They're the ones that gave you the grey hairs. The vast majority were happy with the rapid response system. But it was also resources. Public systems are resourced very differently to private. We'll go into that later. But at that time, there was very little published evidence to actually argue my case. The merit study, unfortunately, being a negative one, really didn't help. But we persevered, and in 2008, we actually implemented the rapid response system at the Richmond facility. And I'm pleased to say, after about 7 years of refinement, we now have a mature rapid response system with a met dose of about 34.5 per 1,000 admissions and a reasonably low cardiac arrest rate. So the outline for this talk looks at governance issues in the private sector, in particular the National Commission's standards, what a typical rapid response model looks like, and how we can actually tweak this for the actual private sector. I think we need to acknowledge, though, that there are differences between the public and private sector, in particularly the demographics of hospital patients, also what the frontline medical response is like pre-activation of a system, the resources, both in personnel and funding, and also the certain limitations inherent to the private sector. Now, in the latter parts of the talk, I'll talk about our approach at Epworth Richmond, how we try to ameliorate some of these limitations. And then lastly, I'll touch on future directions, I think, for the private sector. Okay, so luckily Standard 9 came along because it really mandated that all hospitals, public and private, really had to be assessed against the national standards. So Standard 9 involved, as you all know, establishing the rapid response system, making sure we recognised deterioration and escalated appropriately, also that there was appropriate and timely care, and that there was communication with patients and carers. So this is the framework to which we apply the standards. And some of our forefathers are in the room that actually proposed this sort of model whereby a hospital patient has worsening physiology all the way to met physiology, and if it deteriorated, code blue. And then if we actually implemented an afferent arm which detected this physiology, then activated an efferent arm, we could prevent basically a cardiac arrest by an appropriate met dose. So the other parts of a rapid response system involves a quality improvement arm as well as administrative arm and hopefully a research arm. And through, I guess, peak nursing and medical bodies in the administrative arm, it sort of oversaw the system. One needed executive buy-in as well to help with the system. And in terms of quality improvement through meetings and data collection, there's a cycle of continuous improvement if this data was fed back to the afferent and efferent arm and helped essentially by the education arm of the system. So how do we tweak this model then for the private hospital? I think firstly one has to acknowledge the standards and then acknowledge that actually the private sector has a different landscape to the public sector in terms of the type of patients, the level of illness, what the frontline medical response is like, the composition of the actual salaried staff, also the politics and funding is a bit more challenging in private. But in spite of all the limitations, there certainly are strengths, and we'll go through these. And then taking all this into account, we implement and fine-tune a rapid response system. What about the demographics then and case mix? Well, this is from the Australian Institute of Health and Welfare report, and it looks at all Australian hospitals, from the very small to the very large. And you can see that in the private sector, it's predominantly surgical care with medical care representing less of the case mix. Also, in terms of emergency surgery, we find that in private we're doing much less emergency surgery. It's mainly elective compared to the public sector. Now, it's interesting that 40% really of all hospital admissions are in the private sector. So it's quite a sizable part of Australian healthcare. But you can see that the average length of stay is actually much less. Average hospital stay is much less, average ICU stay is much less, and the level of sickness really is less than in the public sector. If you look at the amount of ICU admissions actually requiring ventilator support as an example, say. This is, I think, quite important. What about the actual number of salaried staff? Well, we don't have many doctors that are salaried in the private sector, and this creates a problem when you want to try and govern a system. We certainly have nurses, which is really good, actually, large proportion of nurses. So really that's where a lot, I think, of the burden of this, they have to shoulder a lot of this, really. So who pays for all this? Well, it's really the health insurance funds. They provide most of the money for private hospitals. Now, I alert you to a sort of a power struggle between three entities there, which, if you're governing a rapid response system in private, you need to be very aware of. And the two sides of that limb, the hospital health fund relationship is particularly important. Really, the health funds have a position of power over the hospital, and often negotiations are quite brutal in what they'll actually pay. So if you want to go to the hospital to resource your rapid response system, you've got to have a very cost-effective argument because the dollars are really stretched tight. The other thing that's important is the VMO, the visiting medical office specialist, who's not salaried, he's actually just a person that comes in and brings the patients into the hospital. They have a very powerful relationship with the hospital, and if there is a conflict between a visiting specialist and the hospital's rapid response system, the hospital has to be very careful because they're actually bringing business into the hospital. So whilst I think it's very important not to let standards suffer because of this, because you can't accept substandard management, but at the same time, there's always the fear that they'll take their business elsewhere, which is quite a relevant thing in negotiation. What about the frontline medical response then between private and public? Well, if we look at the public sector, we've got reasonably junior doctors as the front line, but in private you've got a senior clinician. The junior doctors also sort of meet the patient episodically, and often there's multiple handovers in the public sector of these junior doctors, whereas in private, often the patient is known to the consultant for a very long period of time, sometimes years. The other issue is that in the public sector, it's very uncommon for a doctor to cover multiple sites, but in private this is quite commonplace. So obviously a problem for us. So really in private the presence of a doctor is not constant, whereas in public it is. That essentially is the major deficit then in private, the physical presence, whereas perhaps in public it's to do with seniority and knowledge of the first line medical response. To try and ameliorate this, though, there's a lot of medical co-management of patients. One patient in a private hospital may have multiple specialists looking after them. That's quite common, whereas actually that's not the case in the public sector. So then what are the inherent limitations of the private sector? Well, firstly, the salaried medical workforce is actually quite small. So what we found, certainly at our hospital, which is a very large private hospital, that as the hospital increased in size, the Met dose required to actually facilitate the ICU reg on the Met team just became unsustainable. And we have to manage, we have to rely really on our nurses to shoulder much of that burden. Also, there's a potential problem of delayed or even absent escalation by the visiting medical officer, specialist. They may actually resist any protocols you put in place, and as I said, they may exercise considerable political power. And the other problem is sometimes, often they're not on site and may actually be difficult to contact. So what are the solutions that we've had, say, at the Richmond campus to try and deal with this? Well, in terms of the lack of the ICU registrar funding, we've actually created 24-hour, 7 days a week ICU liaison nurse service, and we find that in fact is actually very helpful, and we've made them the leader of the rapid response team. We've also incorporated the specialist into the efferent arm. So if you look at where they come in, they actually deal with the Met physiology when the afferent arm detects it. Incidentally, for our hospital and other private hospitals that may not have this, we've actually also got a hospital medical fellow who's really a variable seniority doctor who's actually not allied with the ICU, but serves as the sort of pen pusher, I guess, for an off-site VMO who can issue orders over the phone. But this system really is controlled by the ICU liaison nurse, and we find that this actually has a lot of benefits. Certainly nursing expertise has flourished at our institution. It increases the VMO engagement, and it's certainly cost effective. I mean, we estimated to actually have our ICU run a Met service. We needed 5 EFT of ICU registrar to account for annual leave. That in the private setting is somewhere between $600,000 to $800,000, and that just wasn't going to happen. So what about delayed or absent escalation by the primary specialist? Well, we find with the ICU liaison nurse, they can actually refer to ICU. So often it's, sometimes it's with the awareness of the VMO, often it's discreet, but that actually allows us to actually get involved in deteriorating physiology at an earlier level. In many ways, it's a bit Muse-like, I guess, our Met system. We've got sort of a graded response. In fact, to further that idea, we actually implemented some criteria into the Code Blue criteria. So it almost becomes a second effector arm. For example, we put a blood pressure of 70 in Code Blue, meaning that the afferent arm can directly press the button, bypass everything, and get the ICU docs earlier, thus preventing cardiac arrest. And we find this certainly maintains patient safety. What about VMOs resisting protocols or change? Well, certainly our protocols are linked in the bylaws of the hospital to VMO accreditation. And of course there's quite a lot of administration engagement of the VMO into this regard. And we've found over time this really has promoted cultural change. VMOs not being on site, well, the ICU reg will respond if it's time critical. And again, the administration certainly encourages medical co-management. And look, many of our specialists are actually just in private, and in a sense they've become hospitalists, and that's really helped us quite a lot. So this really guarantees a response as the mortality risk increases. What about the VMOs just not responding at all? And that doesn't happen often, but it is a very small fraction of. So medical co-management helps here, but we certainly have a robust audit trail that's fed into the administration, and certainly this, I'm not saying it's always handled very well, but I have found in time that culture is changing and we've managed to reinforce the standards. Look, there are certain inherent benefits in the private sector as well. Certainly what I've found is the senior medical staff at the frontline response certainly has greater diagnostic efficacy and accuracy, I think, because of their seniority and also the excellent longitudinal knowledge of the actual patient. Obviously, there's no frontline hierarchical delays that you might get in the public sector, like intern, registrar, going up the food chain. This goes straight to the specialist on call. Certainly, we found nursing expertise flourishing. We've got some black belt ICL liaison nurses who really are excellent. And the thing about it, they're a constant workforce, so they build on their knowledge. Whereas with the registrars, I find they're changing every sort of 3 to 6 months, and it's difficult to, you've got to keep maintaining the standards. But ICU liaisons nurses seem to have a longer tenure, which is actually quite helpful. We find this obviously is very cost effective as well, because we can present later on in the continuum of illness. So as the mortality risk increases, we find that we're almost purifying the critical illness signal in a way, in that we're really there for interventions like respiratory intervention, central line intervention, with a heads up by the IC liaison nurse. And our doses, you can see up the top there, MET dose of about 35.5 per 1,000 admissions for MET. For code blue, it's of the order of about 5. Now, that's not arrests, don't forget. That's just sort of patients that are a bit sicker. And really, we find a lowish cardiac arrest rate from this system, about 0.25 per 1,000 admissions. So our system looks something like this, where we've got a 2-tier system, with the green tier actually being the MET with specific core criteria, which looks very much like MET core criteria in other places, and a code blue limb as well, with, for example, blood pressure being one that will, the afferent arm can activate directly. The others are fairly sort of standard. But we find that incognito sort of, surreptitious escalation by the IC liaison nurse is very helpful. I'd like to formalise it a bit more. I like the idea of an early warning system, scoring system, and I think there's work we can do to formalise the escalation from IC liaison nurse to medical service in a cost-effective manner. So other aspects of governance, look, in terms of clinical effectiveness, this system is informed by KPIs. We gather data for MET dose, missed METs, cardiac arrest rate, appropriate escalation. As I'm alluding to, I think other systems which have increasing specificity, I think of a critical illness signal, I think is something we should sort of look at as well. In terms of education and training, we have quite a large simulation centre at our facility, and we do multidisciplinary sim with nurses and doctors. We're actually now mandated that advanced life support is mandatory for obviously all intensivists, ED physicians and anaesthetists at our facility. And bravely by the executive, they're mandating that cardiologists do the same, which, well, good on them, they've started. It's going to be challenging, but certainly that's the way they want to go. Clinical audit, we found we've outsourced this to the Department of Quality. We're lucky to have a Department of Quality. I think a lot of smaller private hospitals might not have that, and it might be you have to use innovative ways to actually gather the data. We found that we've been able to use them to measure our performance, and they give us sort of good feedback on what's happening at grassroots level. Openness, I think, in any system is very important. So the visiting medical officers have routine engagement by the executive on really what the system is doing, and they certainly seem to involve them as much as they can in it. It's very often challenging. Some of the visiting specialists have very forthright views, but as I said, I think over time I can see the culture change. In terms of risk management, I think more and more VMOs are realising now that they just don't own the patient solely, even though they're in private, and a lot of them are coming to realisation that the hospital actually does have vicarious liability for these patients, and that any reduction in risk actually is a joint exercise. And another thing, in terms of the standards, are really good. I recently discovered that actually we do now have a bat phone that a family can press, and that goes straight to our IC liaison nurse, just showing the utility, I think, of this position. So what about future directions? Now, look, in private, I look enviously at this room, at the public sector, and really all the good research going on, and really I think that's the next area for us. I think at a hospital like Richmond, where we have perhaps more capacity research than other private hospitals, I think we need to start doing this now. In particular, I think the pre-met physiology is where the money is, I think, in terms of, well, we've got VMOs that are actually looking after these group of patients, and I think we need to research how we can keep it at the pre-met physiology level before they actually deteriorate and we have to become involved. So in summary then, I think private hospitals need to, they require calibration of their rapid response systems against Standard 9. I think there are differences in personnel, funding, politics and resources that will influence the nature of governance in the private sector. And lastly, as I alluded to, I think research, preferably from the private sector, will optimise the clinical effectiveness of rapid response systems in private hospitals. Thank you.